So let me start with a disclosure. I am not an economist, but I would call myself an economoid. That is to say, a health professional who has found the need to speak the language and understand the language of economics so that we can speak the same language as Agnes just mentioned. And precisely my main message today is that we must develop a new way of understanding the role of health in the broader global agenda if we are to execute the policies that can generate progress around the world. Such policies must be based on scientifically derived evidence, which has been the theme of this conference. And as part of this message, the other key message is that this is the time to act in Africa. It is exactly at a time of expansion of health, not of contraction, that the reforms must be put in place. So to elaborate on these messages, I will divide my remarks in two parts. In the first one, I will attempt to examine the context of growing complexity that characterizes the health field, and this will hopefully inform some of our discussions during the next days, and I know that Hans Rosling would provide also a lot of data context. And in the second part, I would like to illustrate the last message by Dr. Kaberuka this morning about the need to adapt lessons from other parts of the world. And I will use some of the examples in Mexico that Dr. Chan also referred to, just to show how some of these policies can be actually designed, evaluated, and implemented. So let me first analyze the complex and changing context we are all facing. The world is experiencing one of the most tense and intense health transformations in human history. During the past few years, health matters have stopped being the exclusive concern of domain experts, and instead health has come to occupy a central place in the most pressing dimensions of the global agenda: economic development, national security, democratic governance, and human rights. In this context of growing global visibility for health matters, their relationship with the economy has become the object of intense scrutiny. For decades, the connection between health and economic growth was viewed as a simple, unidirectional relationship. Economic growth promotes health through better living conditions, including investments in sanitary infrastructure and housing, improved nutrition, and increased access to education. This traditional perspective may sound particularly appealing to the ministers of finance attending this conference, given the recent economic evolution of the African region. As you all know better than anybody else, during the past decade, 6 of the world's 10 fastest growing economies have been in sub-Saharan Africa. The IMF anticipates that this subcontinent will grow by 6% next year, and several of the big countries will probably show economic growth rates of 10%, as the president of the African Development Bank has mentioned this morning. In the past 5 years, Africa also experienced one of the biggest falls in child mortality ever seen anywhere, and this was featured in The Economist and called one of the best recent stories in development. But we should not jump to conclusions. Economic growth by itself is no guarantee. Liberia shows impressive economic growth, 6.9% in 2011, but still high child mortality rates. Senegal, with a relatively modest economic performance, showed the second best mortality rates in children under 5. So there's not a one-to-one correlation. Analysts believe that the recent decline of child mortality in Africa is the consequence of a combination of broad economic growth and successful health policies. And this is the key point. It's that combination. Furthermore, we now also know that good health is not only a consequence, but also a condition for sustained and sustainable economic growth. Now let me be explicit about my ethical framework. As a physician, I believe that health is intrinsically valued and that it represents one of the few truly universal aspirations. Therefore, improvements in health are justified in their own terms. Now, there is no contradiction between this statement and the observation that in addition to its intrinsic value, health also has an instrumental value in contributing to other socially worthy objectives. Thus, good health reduces poverty, protects family assets, improves educational performance, increases labor productivity, enhances the investment climate, and by doing all these things, stimulates economic growth. This point has been proven by several influential initiatives led not by health professionals, but by development economists. Almost 20 years ago, the World Development Report 1993 was devoted to the topic of investing in health. This was probably the first major effort at making the case that health is an investment more than a mere item of expenditure. As the flagship publication of the World Bank, this report had major influence on ministers of finance from around the world. This landmark document was followed in 2001 by the equally influential report of the Commission on Macroeconomics and Health, which demonstrated that a 10% improvement in life expectancy at birth is associated with an annual increase in economic growth of 0.3 to 0.4%. Yet things get more complex. The aforementioned figures refer to the direct effects of improved health on economic growth. But a substantial part of these effects are mediated by the way health systems get organized and financed. And this opens up a whole new dimension of interactions between health and the economy, the institutional dimension. Above and beyond the direct effects of better health on economic growth, the health industry itself has become a major sector of the economy. Globally, according to the WHO, health-related goods and services constitute 10% of the world economic product, around $6.5 trillion. Of course, the OECD countries account for 84% of this money, and the United States alone represents 40%. But even in the poorest countries, health is becoming a major sector of economic activity with huge implications for the performance of the rest of the economy, including key variables like inflation, employment, and competitiveness. The relationship between health and the economy can lead either to a virtuous or a vicious cycle. Productive investment in equitable, efficient, and high-quality health services has a positive effect on all economic activity because it raises the quality of the human capital, improves productivity and competitiveness, creates jobs, encourages scientific research, and stimulates technological innovation. Besides, good health is a necessary condition for equal opportunities. This makes healthcare an essential element in the fight against poverty, and Margaret Chen has emphasized this positive side. But in contrast, unproductive health spending has a negative effect on the economy because it increases inflation, reduces productivity and competitiveness, depletes family savings, propagates bankruptcy, gives rise to inequality, and diverts funds from better social uses. As we can see, there is a fundamental connection between the performance of the health system and the performance of the economic system. This link has occupied center stage in intense debates around healthcare reform in the United States, since a major part of the rationale for fixing its health system has been precisely to prevent all of these negative economic effects. There are two compelling conclusions from this logic. First, it is necessary to end the artificial divide between social and economic policy. These are really two sides of the same coin. If we do this, economic decision makers will be persuaded that investing in health is not only the right thing to do on ethical grounds, but it is also the smart thing to do in order to achieve economic prosperity, as argued in the excellent background papers for this conference. The second conclusion is straightforward. Policies do matter. Although health systems are somewhat idiosyncratic and reflect the specific circumstances of each nation, there is one generalization that we can make when we compare countries. And that is that countries with exactly the same level of income per capita and exactly the same level of expenditures per person achieve widely different levels of performance in their health systems. And what this is telling us is that policies do matter. This is probably why, during the past few years, there has been a growing realization about the importance of health systems and a burst of new initiatives to strengthen them as a key strategy to accelerate progress towards the health-related MDGs. If we are to achieve these MDGs, we need, in the words of the legendary Professor Ramalinga Swamy of India, not only more money for health, but also more health for the money. So the focus is increasingly on accountability for results. Awareness about the importance of health and health systems for economic prosperity have undoubtedly contributed to the impressive expansion of development assistance for health, which increased from less than 11 billion in 2000 to almost 26 billion in 2009. So a 2.5 times increase in overseas development assistance for health. A large proportion of this increase has been appropriately directed towards sub-Saharan Africa, whose share of total development assistance for health tripled from a mere 10% in 2000 to 30% in 2009. In light of this increase, a large part of the discussion around financial reforms has been focused on external assistance. Important as this source of funding has been, especially to accelerate progress towards the MDGs, we should not lose sight of the fact that the vast majority of health financing comes from domestic sources. Thus, in 2009, government expenditures for health from its own sources reached $410 billion in developing countries, which is 16 times larger than all development assistance for health. In the African region, external sources represent only 11% of the funds spent on health. Historical experience makes it possible to predict with reasonable certainty that as African economies continue to grow, they will inevitably face a rise in health expenditures. The challenge then is to assure that those increased investments yield the best possible results by attaining two types of efficiency. Allocational efficiency, which comes from assuring the optimal mix of priority interventions, and technical efficiency, which comes from producing those interventions with the best possible use of resources. This is the time for getting these policies right, at this time when we can predict that expenditures will grow. Once you create a vested series of interest around entrenched, inefficient health systems, it is very hard politically to introduce the necessary change. The imperative to improve health system performance is underscored by the fact that we are living in a time of unprecedented change. Low and middle income countries are witnessing a particularly complex, protracted epidemiological transition. Indeed, the developing world is simultaneously facing a triple burden of ill health. First, the unfinished agenda of infections, undernutrition, and maternal mortality, mostly concentrated in sub-Saharan Africa and South Asia. Second, the emerging challenges represented by non-communicable diseases, mental disorders, and the growing scourge of injury and violence. And third, the health risks associated with globalization, including the threat of pandemics like AIDS and influenza, the trade in harmful products like tobacco and other drugs, the health consequences of climate change, and the dissemination of harmful lifestyles. Setting priorities has become tougher because problems only of the poor, like malaria or maternal mortality, are no longer the only problems of the poor, who also suffer from higher rates of non-communicable diseases, injury, and mental disorders. In dealing with this complex picture, business as usual will not do. The world as a whole requires a new generation of innovations, not just in technologies, but also in the way we organize and finance health systems. In the search for these innovations, rigorous evidence must be the driving force in the formulation of public policies, which is one of the central themes of this conference. Recent innovations in the design, implementation, and evaluation of social policies in Mexico illustrate the uses of evidence to improve health. So I will now turn to a brief discussion of them. But before I do so, let me clarify that even though Mexico is a middle-income country, its high degree of social inequality means that it represents the gamut of health problems affecting the entire world. Because the policy innovations I am about to describe have been focused on the poor with a strong emphasis on equity, I believe that they are relevant to low-income countries, including those in Africa. And again, this was emphasized by the president of the African Development Bank this morning. The first example is a comprehensive initiative implemented in the late 1990s to enhance basic capabilities of families living in extreme poverty. This program, called Oportunidades, Opportunities, creates incentives for families to invest in their children's human capital through what have been termed conditional cash transfers. That is to say, targeted income supplements that are conditioned on the fulfillment of certain elements of co-responsibility. 3 of these requirements are salient. First, sending children to school rather than work. Second, attending a clinic in order for the family to receive a specified package of health promotion and disease prevention interventions. And third, providing a specially formulated nutritional supplement to pregnant and lactating women and to children under 5. Among its many innovations, this program has adopted a gender perspective in that the cash transfer is provided to women who are thus empowered by their control over family resources. I will not go into any detail because there's a huge literature on the cash transfer. I will only say it's been a hugely successful one, and I would like to emphasize that in a decision that proved to be visionary, the Mexican government decided from the outset to do a rigorous evaluation of this program, and thanks to that evaluation, this type of conditional cash transfer programs have expanded so that, for example, in Latin America and the Caribbean, there are similar programs benefiting now 75 million people. Conditional cash transfers have also extended to other areas in the health field. For example, in India, we have the National Rural Health Mission program, which has been promoted facility-based deliveries using a similar scheme. However, in health matters, we are always victims of our own success. So even as Oportunidades was proving its value in reducing poverty and improving health, the beneficiaries were experiencing new disease burdens because all those children who survive are now going to be suffering non-communicable diseases. All those mothers that don't die in childbirth are now going to live enough to develop cervical cancer or breast cancer or diabetes. So new challenges were coming to the fore. So on the basis of the successful platform afforded by Oportunidades, we launched in the year 2003 a major health reform that basically allowed us to extend universal health insurance, as Dr. Chan mentioned just a while ago. Again, I'm not going to go into any detail because there's a huge literature on this reform, and I know we're falling a little bit behind schedule. I would urge any of you who are interested to consult that literature, especially a series of 6 articles that were published in 2006 in The Lancet, and an update with the most recent evaluation of this reform will be appearing online again in The Lancet in the month of August. So you have a very, very extensive body of evidence showing that this has actually worked. But let me just say that this reform started with a very serious effort at analyzing problems, with an exercise in national health accounts that revealed that most of the expenditures, contrary to expectations, contrary to prior beliefs, most of the health system was being financing with direct out-of-pocket expenditures. And this is the problem affecting now most countries, both in North Africa and in Sub-Saharan Africa. And this was leading, in the case of Mexico, to about 4 million households becoming impoverished every year because one member of that household experienced a health episode. Again, the same problem you're facing here. This created the political will to change this situation because we argued that this was an unacceptable paradox. We know that health is one of the most effective ways to empower people to lift themselves out of poverty, yet spending on health becomes itself a major cause of impoverishment when countries do not provide the social protection that's needed to protect families when there's an episode of illness. It was a very careful design of a new financial architecture, including 3 funds, one to fund essential health services, primary and general hospital level, with a large number of about 215 interventions, a second reserve fund for high-cost catastrophic expenditures, and then very importantly, a third fund for protecting community interventions, the upstream early detection and health promotion interventions that avoid the cost of failing to prevent episodes of illness downstream. Let me also say that in this whole process, we had the enormous support of the Minister of Finance, who was very much persuaded that this was not just good social policy, but this was also good economic policies, because it was possible through good evidence to show the devastating effect that spending out of pocket was having on productive assets and on the savings rates. And on the other side, he understood the enormous economic benefits of sound economic policies. I will skip and I will leave with the organizers the full text, and I hope this will be distributed, but for the sake of time, I will skip all of this part and just finish by a formula that I have found is very good to remember the main lessons from this successful reform experience. And we wrote this in those Lancet articles. I call it the ABCDE of successful reform. A stands for agenda. The first ingredient for success is to advance the health agenda amidst competition for attention, political attention, and public resources. Especially in the interaction with ministers of finance, health officials can make use of global evidence showing what we have seen, that this is one very good investment. If we take care of the A, then this leads naturally to the B. The B stands for budget. Again, it was said this morning by Margaret Chan, most countries, most developing countries, are spending below what would be efficient in order to achieve and reap the full economic benefits of investing in health. But for that expanded budget to be useful, we need to pay attention to the C. And the C stands for capacity. There's no replacement to building capacity in two directions: strengthening the overall delivery system in a diagonal strategy that uses clear intervention priorities, but uses those to drive general improvements into the way the health system operates. And the second area for capacity building is to build the capacity to do the evaluation that's required to be able to monitor progress along the implementation of reforms. If we do the C, then we can move to the D, which are deliverables. A key ingredient to gain public support for a reform is to identify and communicate its specific benefits. The best way is to focus on priority diseases and risk factors, and this way the public can link abstract notions like insurance to concrete deliverables. In this respect, in your conference materials, you will find a review of promising tools to improve domestic financing. It is in your conference documents. And this demonstrates that investing in high impact and cost-effective interventions can improve value for money. This is the deliverables. To support policymakers in identifying these interventions, the Partnership for Maternal, Newborn, and Child Health, the World Health Organization, and the Aga Khan University published in 2011 the 56 essential interventions that we should strive to make universally available to women and children. And finally, the E, after the deliverables, is of course the evidence. E stands for evidence. Because as we have seen, sound evidence is a powerful instrument to build political consensus and steer the way towards successful reforms. And international organizations, such as the conveners for this conference, have a crucial role to play in building the knowledge-related global public goods that may enable a process of shared learning among countries, which is why we are all here. Let me finish by one last reflection. Of all the ingredients for success, the most important one is effective, informed, and committed political leadership. The Minister of Finance plays one of the most critical roles, since he or she must balance demands for increased health investment with all the other functions and responsibilities of governments. To help ministers of finance think about how to do that, learn from other countries how they approach similar health financing challenges, and share experience among fellow ministers of finance, the Harvard School of Public Health and the African Development Bank are jointly developing a ministerial leadership in health program for ministers of finance. The first cohort of about 15 ministers will be invited to Harvard in November this year. The objective of the forum is to provide a non-political, informal environment for exploring innovative health financing options and international experience in successful expansion of coverage, access, and quality of healthcare. The forum will be led by senior Harvard faculty, together with a small group of distinguished, long-serving, and former ministers of health and of finance. Just a month ago, we welcomed the inaugural cohort of 16 serving health ministers to Harvard for the first Ministerial Health Leaders Forum. The evaluation from the ministers who participated was overwhelmingly positive. A number of them are here today, including, of course, our chair. And this program will be announced and launched this evening at the dinner. The concept of mutual experiential learning based on the notion that you are all accomplished leaders with valued experience and insight is a core feature of the highly participatory nature of the Harvard Ministerial Leaders Forum. We are very excited about the prospect of engaging now not only with ministers of health, as we did last month, but also now with serving ministers of finance, and we look forward to a mutually enriching experience. I thank you once again for the honor of inviting me to share my thoughts with you around the common search for more equitable development through better policymaking in Africa and indeed in our entire interdependent world. Thank you very much.